Good morning, everyone. Um, I'm Dr. Valari. I'm one of the nephrologists at the medical center here, and I'm the director of hemodialysis here. And I'm going to present a sort of a pretty much theoretical and practical lecture on renal replacement therapy. I'm going to be talking specifically about artificial treatments, dialysis, and my colleague, Dr. Cohen, will be giving a subsequent lecture on renal transplantation. So I'm going to talk about both hemodialysis and peritoneal dialysis. So for good or for bad, I have no conflict of interest or financial disclosures to tell you about. So anything I endorse is my opinion or based on the available medical literature. So what I want to cover is what is the function of the kidney as both an excretory and endocrine organ, and you've probably heard most of it already in previous lectures. What are the indications for providing renal replacement therapy? I'm going to talk about the basic principles by which dialysis works, chiefly diffusion and convection, and then talk about the two different modalities that are used for artificial renal replacement therapy, hemodialysis and peritoneal dialysis. And at the end, I'll touch on the endocrine aspects that need to be replaced in people with advanced renal failure, both in terms of anemia and erythropoiesis that the kidney plays a key role in, and what we now call CKD, MBD, chronic kidney disease, mineral and bone disorder. And I realize you've already had a lecture from our local expert, Dr. Thomas Nicholas, but I'm going to cover it also again from a practical aspect with regards to vitamin D therapy. So what are the principal functions that the kidney does that we have to address when organ function has gotten to too low a level? So one is removal of one principal function, removal of nitrogenous waste products that have accumulated because of inadequate excretion by the kidney. Second, to control or bring back into balance fluid and electrolyte disturbances. And along with that, controlling acid-base balance. And then finally, the two endocrine aspects, stimulation of erythropoiesis and vitamin D metabolism. So what is the uremic syndrome? So it's we actually don't even know which nitrogenous waste products actually produce the uremic syndrome. There are dozens and dozens of nitrogenous waste products that accumulate with reduced renal function, and they produce a variety of symptoms that can affect basically most organs in the body. So in terms of the gastrointestinal tract, people will develop anorexia, nausea, vomiting, altered taste sensation, and with very severe uremia, they can actually get internal bleeding in terms of gastritis and colitis. In the skin, a very common manifestation is just dry skin with itching. And I haven't seen this in my years of practice, but it used to be described that people with very advanced uremia would actually you get urea and other nitrogenous waste products, but mostly small ones like urea, that will accumulate in sweat. And with insensible perspiration, literally those solutes will actually coat the outside of the skin, and it's called uremic frost. And if I ever see one, I'll take a picture of it because I've never seen it in my years of practice. Then cardiovascular disease. Most common symptoms are shortness of breath related either to volume overload or to severe acidosis and the respiratory compensation that the body tries to achieve with that. And then chest pain, and here I'm not talking about angina, but actually pericarditis, which is a uremic manifestation. Central nervous system manifestations are a change in mental status due to the accumulation of uremic toxins, and there are also peripheral manifestations involving the peripheral nervous system in terms of myoclonus and asterixis. So those are things you can see in people who have advanced uremia, at which point they need dialysis. So urgent indications for dialysis: when someone develops intractable nausea and vomiting, pericarditis, change in mental status, meaning encephalopathy, those are clear indications for needing to start dialysis. Most of the time when we see people have progressive chronic renal failure headed towards dialysis, we try to prepare them for treatment and initiate treatment either right before or very soon after developing any symptoms. Other indications for dialysis would include congestive heart failure that is unresponsive to medical management. So dietary salt and fluid restriction, diuretic therapy no longer works, and it's because of advanced renal failure, dialysis becomes indicated. Gastrointestinal bleeding due to diffuse gastritis or colitis as a manifestation of uremia as opposed to another cause, such as infection or peptic ulcer disease. Life-threatening electrolyte abnormalities, hyperkalemia and acidosis, again, when they become refractory to medical management through diet and medications by which we try to manipulate and control the potassium and acidosis. And then finally, at very low levels of renal function, we try to prepare people for dialysis, which includes transplantation, and initiate treatment when their clearance is very, very low and we anticipate that they're going to develop the uremic symptoms soon. And that's usually around an estimated glomerular filtration rate, usually less than 10, although some patients with concomitant other medical problems, especially cardiovascular disease, such as severe congestive heart failure, often may need to start when the clearance gets down below 15. And I'll talk about KT/V a little later. Dialysis alone isn't sufficient to control the uremic syndrome, and so there's other things that need to be done, chief of which is diet. And so patients are given dietary instructions to restrict salt intake, potassium intake. We want adequate but not excessive protein intake because that just leads to excessive accumulation of nitrogenous waste products. And then we have to provide more dialysis in order to clear those, and there's really no benefit. So what's usually recommended is somewhere between 1 to 1.2 grams per kilogram body weight per day of protein intake. And then, of course, fluid restriction. And as a rule of thumb, patients can actually restrict themselves just to their approximate urine output plus insensible fluid losses, which is about 500 cc's a day through the skin and respiratory tract. Although for most patients, to make it simple, we usually fix it at about a liter a day of fluid intake. Then all medications that patients are on, we review them and dose adjust them for the reduction in renal function. And usually they're reduced in proportion to the percent reduction in renal function. Antibiotics are a common example. And then in terms of over-the-counter medications or other medications that the patient may take or dietary supplements, we want to instruct them on avoiding substances that depend on renal clearance for elimination. And probably the three biggest ones are that we would worry about is potassium, magnesium in antacids and laxatives, and phosphate, which is in some laxatives. And then we, of course, want to avoid overhydration. So especially when patients come into the hospital and need treatment, and if they've had symptoms that suggest they might be dehydrated, even there, fluid replacement has to be done cautiously. So what do we do with dialysis? So I guess one way to think of dialysis, this is a crude idea, is that you consider the dialysis treatment as sort of a single large glomerulus, which is one of the problems with the treatment, is that whereas a kidney will filter the plasma and then process it through the renal tubules, and you've had lectures on that, with dialysis, essentially, we're filtering the plasma, and that's about the best we can do. But similar to the glomerulus, what we use is a semi-permeable membrane that allows us to alter the concentration and composition of the body fluid, trying to bring it back towards homeostatic balance. And the two basic physical forces that we use to do that is diffusion and convection. So first, diffusion, or diffusive clearance, it's based on Fick's principle. So the flux of any solute, the nitrogenous waste products we're trying to clear, plus other electrolytes that we're trying to correct, the solute flux across the membrane will depend on the diffusivity, which is the permeability of the solute to the membrane. And that will depend on the properties of the solute. Typically, it's molecular radius, and in some instances, it's charge, the solvent that it's in, which in this case is water, and specific characteristics of the membrane that are altered in the manufacturing process that will affect the clearance that we achieve. And this includes the size of the pore, the density of the pores on the membrane, and even the thickness of the membrane, and in some instances, the charge of the membrane. So somewhat similar to what you've probably learned about the glomerular basement membrane and its function. The other two important factors is the surface area. So a larger surface area of contact between with the blood will achieve better clearances, and the concentration gradient across the membrane obviously will determine the flux across the membrane. And to a limited extent, there are things we can do to alter that characteristic. So this is just a cartoon to demonstrate what I was talking about. So based on the size of the solute in relationship to the size of the pore size and and the density of pores along the membrane, and even the thickness of the membrane, and then the concentration gradient from one side of the membrane to the other will determine the diffusion of solutes across that membrane. The other major physical principle is that of convection or convective clearance. And this is the movement of a solute across the membrane in response to solvent flux. So it's also referred to as solvent drag. So the idea is that you ultrafilter the solvent, which in this case is water, the plasma water, and then solutes will be, in a sense, dragged across the membrane, probably because of alterations in the microenvironment in terms of concentration, essentially allowing diffusion on a local level, and we call that as convective clearance. The interesting thing about convective clearance over diffusive clearance is that both achieve good clearance for small molecules, and for reasons that I'm going to say I don't fully understand, convective clearance with the same size of pore and density of pores, convective clearance will actually achieve better clearance for larger molecules, some of which are uremic toxins that we try to remove. So in comparing diffusion and convection, diffusion is slightly more efficient at clearing small molecular weight species, those less than 500 Daltons. And it's the main mechanism by which we correct electrolyte disturbances, things like disturbances in potassium, calcium, magnesium, and phosphorus as examples. Convective clearance is actually more efficient at clearing larger molecular weight species, what we call middle molecules, many of which are uremic toxins. And it's by convection that we correct salt and water balance by the process of ultrafiltration. So in hemodialysis, we have blood traversing along a path. It's in contact with a semi-permeable membrane. On the opposite side of that membrane is I should have put this in quotations, a near physiologic saline solution. And we'll talk about why it's not exactly physiologic, which we call the dialysate solution. And then molecules diffuse down their concentration gradient in either direction, either from blood to dialysate, the things we're trying to remove, or in the reverse direction, from dialysate to blood that we're trying to restore to the patient, chiefly bicarbonate loss due to titration of bicarb by the accumulation of acids from intermediary protein and carbohydrate metabolism. And this diffusion process brings them into near equilibrium. So this is just sort of a cartoon showing that we draw blood from the patient, and it's driven by a pump through a cartridge. Cartridge consists of several hundred long fibers, capillary tubes we refer to them, which is the semi-permeable membrane. And then the blood is delivered through the dialyzer and then recollected and returned to the patient. Running around and outside these capillary fibers is the dialysate solution, and it runs in a countercurrent or opposite direction, mainly because that achieves the optimal or the best concentration gradient to favor diffusion and correction of the electrolyte and solute abnormalities. So then how does dialysis achieve the goals that I sort of outlined at the beginning? So removing the excess nitrogenous waste products that have accumulated in renal failure is chiefly by diffusion, obviously because the dialysate will not have any, so you'll get a maximal concentration gradient and the removal of nitrogenous waste products. In terms of controlling fluid and electrolyte balance, in terms of salt and water balance, we do it by ultrafiltration. A pressure gradient is applied across the membrane, which leads to the ultrafiltration of plasma. The major solute in it is sodium chloride, salt. That will that will convect across the membrane by the process of convection. And it's by that process that we remove salt and water that the patient has accumulated in between dialysis sessions, and that's how we achieve balance. And the other electrolytes and minerals, that's by diffusion across the membrane. And again, the dialysate solution is roughly physiologic, so it'll favor electrolytes or minerals that are in excess in the blood to diffuse into the dialysate, or restore it in the opposite direction if they're deficient in the blood. And then finally, controlling acid-base balance, again, through intermediate metabolism of proteins, carbohydrates, fats, you generate acid. The acid titrates bicarbonate and other body buffers. So what we do is we use a dialysis solution that has a supra-physiologic concentration of bicarbonate to create a concentration gradient that favors the flux or diffusion of bicarbonate back into the body to bring the patient's bicarbonate up to close to normal. So it's by that process that we correct the bicarbonate loss, and then the organic anions that have accumulated from protein, carbohydrate, fat metabolism, those are then removed by diffusion. And so that's how we restore the acid-base balance. Turning alternatively to peritoneal dialysis, there we use the visceral peritoneum as the semi-permeable membrane across which the process of dialysis occurs. So blood circulates through the peritoneal capillaries, which is basically one side of the membrane, quote unquote, and it comes in close proximity with again, a physiologic or near physiologic saline solution, which is the dialysate, which we instill into the peritoneal space, which is a potential space, but you fill it up with fluid, and we do that through an intra-abdominal catheter. So then you have blood on one side, dialysate on the other side across the visceral peritoneum, and again, by the same processes of diffusion and convection, the process of dialysis occurs. So just as a drawing, so a catheter is inserted, implanted under the skin, and placed into the peritoneal cavity, and the dialysate solution is simply instilled into the peritoneal cavity through the catheter and sits in the peritoneal cavity, and slowly over time, the process of dialysis through diffusion and convection occurs. So in comparing hemodialysis with peritoneal dialysis, hemodialysis achieves most of its clearance of solutes, again, nitrogenous waste products and electrolytes by the process of diffusion. A much smaller amount is removed by convection. Again, we achieve salt and water balance by the process of ultrafiltration. And this is driven by applying a hydrostatic pressure gradient that is regulated by the dialysis machine. That pressure gradient drives ultrafiltration of plasma water across the membrane. And again, salt follows through solvent drag, and we achieve salt and water balance. For peritoneal dialysis, it's still predominantly diffusion, but uses slightly more convection also in terms of achieving clearance. Now, in terms of how we achieve salt and water balance, what we actually use is, rather than a hydrostatic pressure gradient, we use an osmotic pressure gradient. So the dialysate solution is made with hypertonic glucose concentrations, anywhere from 1.5% up to 4.25%. And there's even a newer solution that we can use, which actually is a large, non-absorbed carbohydrate polymer. And the idea is that these create an osmotic pressure gradient that will essentially draw water from the plasma into the dialysate solution. And then again, by convection, salt and other solutes will follow. But most importantly, we then achieve salt and water balance by using an osmotic pressure gradient to ultrafilter the plasma and remove excess salt and water that the patient has accumulated through their diet. Now, so in order to provide dialysis, these are artificial treatments. We need access that people are not born with. So for hemodialysis, in order to be effective the way conventional dialysis is currently done in the United States and across the world, we have to get blood flows of at least 300 and more typically 400 to 500 cc's per minute, which you can get from an artery or you can get from a deep central vein, but they're not readily accessible on a repeated fashion. Patients' standard hemodialysis in the United States and across the world is done on a 3 times a week basis. So we need access to the circulation, achieving this degree of blood flow 3 times a week. So what's done is an artificial creation called an arteriovenous fistula. And this is where a surgical anastomosis is made between an artery and a superficial vein in the body, usually in the arm, allowing the vein over time to grow and mature into what is essentially a superficial artery that we can then access and will have adequate blood flow to provide adequate dialysis. When patients don't have adequate veins to create an arteriovenous fistula, an artificial vein is implanted in the arm called an arteriovenous graft and then anastomosed to an artery and a more central vein. And for patients who can neither get either of those or need to start dialysis urgently, we place a large dual-lumen central venous catheter, typically in the internal jugular vein, with the catheter ending in the low superior vena cava at the superior vena cava atrial junction. And we use that to get adequate blood flow for treatment. As I said, in peritoneal dialysis, we place an intra-abdominal catheter surgically through which the dialysate solution, typically between, depending on the patient's body size, anywhere from 1.5 liters to 3 liters with each installation into the abdominal cavity to provide dialysis. So then a simple cartoon drawing. This is sort of a picture of the classic, what's called Brescio-Cimino arteriovenous fistula. This is where they make a side-to-side anastomosis of the radial artery to the brachiocephalic vein at the wrist. And again, the vein over time, in response to the higher pressure and flow due to this anastomosis, the higher pressure and flow causes the vein to dilate, and the media of the vein to actually, the muscles to hypertrophy and undergo hyperplasia, and essentially transforms the vein over a period of several months from a vein essentially to an artery. If you were to take a biopsy of it and look at it under a microscope, the average pathologist might have trouble telling whether it's really a vein or an artery. And it's that vein through which needles are placed to draw blood out and bring it to the dialysis machine to go through the filter and then to be returned to the patient in sort of a continuous loop to make the process efficient. And again, for patients who don't have adequate veins or have failed, an artificial vein called a graft is inserted, and it's attached to the artery and vein. One common setup is to attach it to the brachial artery at the elbow, and the graft, it's not a good drawing actually, the loop actually extends throughout the whole forearm and then is returned to a vein, usually around at the elbow, for patients who don't have adequate veins. There are several ways that dialysis is provided. This is what we call standard or conventional dialysis. The average patient typically requires about 3 to 4 hours per session delivered 3 times a week. You probably are aware that morbidity and mortality on dialysis is extremely disappointing, and researchers are always working on trying to find ways to deliver dialysis better to try to improve patient outcomes. And I have to say, most of the studies that have been done over the last 2 decades have, for the most part, not established better therapies in terms of outcomes than what we currently do, but things that are being studied, and patients are actually on these treatments, and we'll probably know only in the next few years whether long-term outcome on dialysis is actually better, whether we can improve survival and lessen complications, particularly cardiovascular complications. So one is nocturnal dialysis, where the patients still treat 3 times a week, but instead of 3 to 4 hours at a center, they treat for 8 to 10 hours overnight, done at reduced blood and dialysate flow rates, so that it's better tolerated. The longer treatment allows fluid to be removed much more slowly and then better tolerated. And again, the middle molecules, those things that I described in the 500 to 5,000 molecular weight, actually get cleared better when there's longer contact time between the blood and dialysate, since the process of diffusion occurs too slowly. So the longer contact time helps remove these larger molecules. So long term, these patients may do better, but only time will tell. And then an alternative form of treatment that actually patients are trained and do at home is what's called short daily hemodialysis, where instead of treating for 3 to 4 hours 3 times a week, they may treat 2 to 3 hours, but up to 5 or 6 times during the week. The total amount of time on treatment will be slightly longer, but the advantage of this more frequent intermittent treatment is that you overall get better clearance. So and again, by doing an increased number of treatments, there's less fluid that has to be taken off per treatment, and that leads to better hemodynamic tolerance on the patient's part. And what has been shown with short daily dialysis is that patients achieve better volume control and therefore better blood pressure control, and solute clearance is improved, and so things like phosphate, hyperphosphatemia, is better controlled. And so, in theory, those kind of surrogate markers should produce a better outcome in terms of better blood pressure control. And I'm sure you had the lecture, complications of chronic hyperphosphatemia, in chronic kidney disease patients. So in theory, this should result in a better outcome. But again, it's a relatively new modality of treatment. It's only been around several years. The number of patients that elect to do this treatment is small, and so only time and an increased number of patients on this therapy will we see if this results in better outcome. Likewise, peritoneal dialysis has different flavors or ways we can do it. The standard that was first developed was called continuous ambulatory peritoneal dialysis. This is where the patient does 4 exchanges a day, again, depending on their body size, between 1.5 to 3 liters. So they instill the dialysate into their peritoneal cavity. They're trained to do this at home, and the fluid sits there for about 6 hours with slow diffusion and convection, removing solutes and nitrogenous waste products, and then 4 times a day, they drain out the old fluid and put in the new fluid. An alternative form of treatment is called automated peritoneal dialysis or cyclotherapy. That's where patients are trained at home to use a machine that will essentially pump the fluid into their abdomen and then let it drain out. And they'll typically set up the machine, go to sleep, and the machine will deliver 4 to 5 exchanges overnight, each lasting about 2 hours. The choice of one modality over the other, for example, CAPD versus APD, does partly depend on the characteristics of the patient's membrane. So it turns out that patients have different transport characteristics in terms of how fast solutes will flux across the membrane. When the solutes flux very fast, automated or cyclotherapy at night is efficient. When it fluxes slowly, then you need longer dwell times, and so CAPD is favored. So for some patients, they have to go on one modality versus the other based on their own intrinsic membrane characteristics. Some patients fall in the middle and can choose either, and then it's a personal choice for the patient which they would prefer to do. And then finally, there's combination therapy called continuous cyclic PD, which is basically a combination of the 2 forms of treatment, where the patient will do cyclotherapy at night, 3 to 4 exchanges, and then during the day, not do 4 exchanges, but 1 or 2 long dwell exchanges, and so have the advantages of both CAPD and APD. How do people choose what therapy to go on? So there are pros and, as with everything else in life, there are pros and cons to both forms of therapy. So for hemodialysis, and this I'm talking about in-center treatment, where a patient goes into a center 3 times a week to get treated. The major pro is that it's simple. It's simplest from the patient point of view. Come in, sit in the chair, get treated, and after a few hours go home. But have to do it 3 times a week. The disadvantages are the need for avascular access, which can be difficult to create and maintain in some patients. Dietary limitations becomes very strict. Instead of someone having continuous renal function 24/7, here they're getting treated maybe 3 to 4 hours, 3 days a week. The rest of the time they have no kidney function. So dietary limitations that I described earlier are pretty severe. And then again, being tied to go to a center 3 times a week does affect their quality of life and impair their personal freedom. As opposed to home therapies, and here I'll specifically mention peritoneal dialysis, for many patients who want to take care of themselves, this allows them to participate more in their care, have more control over their care, give them somewhat greater flexibility. Another advantage of peritoneal dialysis, it's slower, continuous, gentler therapy, and it's good for patients who have a tendency to cardiovascular instability. Patients with congestive heart failure and very depressed ejection fractions will often do better on peritoneal dialysis because it's slow and continuous rather than the rigors of hemodialysis. When you're getting hemodialysis and you're treating 3 times a week, you're essentially going roughly every other day. So all the waste products, salt and water that patient has accumulated in 2 days then has to be taken off in 3 to 4 hours. And so if they have poor cardiovascular status, they would do better on peritoneal dialysis. And because peritoneal dialysis is essentially, even if it's done every night, it's more continuous, it results in less dietary restriction. And some of the diet I described in an earlier slide is what we recommend for patients on intermittent hemodialysis. Many patients on peritoneal dialysis have almost no fluid restriction. The downside of peritoneal dialysis is they have a catheter implanted in their abdomen, so there is a risk of infection.
peritonitis. For diabetics, as I mentioned, we use a hypertonic glucose solution in order to get convective movement and removal of salt and water. Some of that glucose obviously diffuses into the patient, and so that can affect glycemic control in diabetics. Because there's fluid anywhere of around, like I said, 1.5 up to 3 liters placed into the abdomen, it increases intra-abdominal pressure, and patients who might have defects in their abdominal wall may develop hernias, which becomes a problem. And finally, because of if patients have recurrent episodes of infection, peritonitis, or sometimes having to use very high glucose-containing solutions in order to achieve adequate ultrafiltration and removal of fluid, patients, again, either with recurrent peritonitis or with using high glucose concentration solutions, the 2.5%, the 4.25%, are at risk for something called encapsulating peritoneal sclerosis, where essentially the membrane becomes fibrotic and scarred, and then they lose dialytic capacity. Now, how do we achieve adequacy? So protein catabolism in the body generates urea and other nitrogenous waste products in essentially a linear fashion. And though we don't measure all the other nitrogenous waste products that patients develop, we measure urea as a marker for how much protein catabolism is occurring and how much nitrogenous waste products the patient is accumulating. So adequate dialysis requires that we achieve a balance between removing all the nitrogenous waste products that are generated in an intermittent fashion. Again, we use urea as our surrogate marker, and we calculate the urea clearance, and we standardize it to what's called the urea space, which is essentially total body water. And the goals of therapy currently are set by national guidelines. And as I said before, with these newer modalities, nocturnal hemodialysis, short daily hemodialysis, what defines adequacy may change over time. But on standard 3 times a week, the current way we practice seems to is the best we can achieve with 3 times a week treatment. And studies that have tried to increase the amount of clearance per treatment have actually not shown a benefit to date. So for conventional 3 times a week dialysis, the 2 measures we use is urea reduction ratio and what's called the normalized urea clearance. The urea reduction ratio is the simplest to understand. We just measure the amount of the percent fall in urea with each treatment. And achieving about a 2/3 correction in the urea concentration 3 times a week achieves what we currently set as adequate dialysis. And again, there was 2 studies done to try to increase that to a much higher level, going instead of 65%, going to 75%, and not able to show a benefit, which is why we kind of sit with the same amount as we did before. And then something similar to that called the normalized urea clearance, or we call it the KT over V, where we measure clearance in a more formal fashion. And so it's based on the K, the urea clearance, provided by the dialysis machine, times the length of the dialysis treatment, so that the product, K times T, gives us the total urea clearance in terms of volume cleared, volume of plasma that has been cleared, and we normalize it to the urea space. And a value of 1.2 or better currently defines adequate treatment. CAPD actually has a slightly lower set point, partly because it achieves better middle molecule clearance because it relies a little bit more on convection than diffusion. And so the standard of adequacy is a little bit, to achieve adequacy is actually slightly lower in terms of needed urea clearance because it compensates with clearing the other solutes that hemodialysis doesn't clear as well. And likewise for short daily hemodialysis, because it's shorter but more frequent treatment, there's sort of a different standard currently in terms of what defines adequacy. Then moving on to the endocrine aspects of dialysis. So the kidney, the interstitium of the kidney, there are cells that produce erythropoietin in response to the local oxygen tension that the cells sense, and that hormone, erythropoietin, is what stimulates erythropoiesis in the bone marrow. When the kidney is diseased, there's less production or inadequate production of erythropoietin, and patients develop anemia simply from relative erythropoietin deficiency. Dialysis doesn't provide that, but we actually give the hormone on treatment to correct the anemia that occurs with chronic kidney disease and end-stage renal disease. And there are 3 forms that are available. There's the original drug, erythropoietin alpha, And there are two longer-acting forms that have been developed that are marketed and available for use, darbepoetin and pegensitide. I won't say much more about them now. The other thing that the kidney does as an important endocrine function is that, the proximal convoluted tubule contains the 1-alpha hydroxylase enzyme that activates and converts 25-hydroxy vitamin D to its active form, 125 vitamin D. People with advanced chronic kidney disease have reduced activity of the 1-alpha hydroxylase. We used to think it was because they just had loss of nephron mass, loss of mass, kidney tissue, although now we found that it's actually because of, and you may have had this from your previous lecture, although I'm going to mention it again, increased release of FGF23, fibrous growth factor 23, which actually is what causes or inhibits the 1-alpha hydroxylase in the proximal tubule. So that there's inadequate, but regardless, that it results in inadequate production of activated vitamin D in advanced chronic renal disease. And so what we do is, on dialysis, we can administer a pre-activated or 1-alpha hydroxylated form of vitamin D, the original calcitriol, and then two modified forms of calcitriol, paracalcitol and doxorcalciferol, that we have available to administer patients to correct their vitamin D deficiency. In terms of complications, long-term complications of chronic kidney disease, specifically end-stage renal disease, the major one and the major cause of morbidity and mortality in patients on dialysis is cardiovascular disease. And it's due both to accelerated atherosclerosis affecting the intima from hypertension and probably uremic toxins, but also an entity referred, I think I had it backwards, uremic calcific arteriolopathy. And it's due to the disordered calcium phosphate metabolism and PTH and vitamin D metabolism that exists in people with advanced chronic kidney disease and those on dialysis. And what happens is vascular smooth muscle cells undergo a transdifferentiation stimulated by the hyperphosphatemia and hyperparathyroidism, and they basically transdifferentiate into osteoblastoid type cells. They lay down matrix, which then, in the setting of a high calcium phosphate product, essentially calcifies the matrix so that the media of the blood vessel turns into essentially bone and then malfunctions. The second most common cause for morbidity and mortality in dialysis patients is infections. And not to go into specifics, but every single cell of the immune system, antigen-presenting cells, B cells, T cells, leukocytes, macrophages, you can show in a variety of in vitro testing that in a uremic environment, all these cells malfunction, and patients are more susceptible to encapsulated bacterial infections. And it's a major cause of both morbidity and mortality. You've already had probably lectures on the mineral and bone disorders associated with chronic kidney disease, and it runs the gamut from secondary hyperparathyroidism to osteomalacia from functional or absolute activated vitamin D deficiency to osteoporosis, or in many patients, a combination of all three. We mentioned pericarditis as a complication of chronic kidney disease and pericardial effusions. That's usually managed with effective dialysis. Hypertension resulting in left ventricular hypertrophy. Again, middle molecules and things larger than that accumulate in chronic kidney disease, and they're not effectively removed. So one such molecule is beta-2 microglobulin, and when it gets metabolized, it can actually deposit in tissues as a form of amyloidosis. So patients who have been on dialysis for more than 10 years may develop this complication and have amyloid deposition in their tissues, the most serious manifestation being an autonomic neuropathy related to the amyloid deposition. And then everyone with chronic kidney disease has whatever you want to refer to it as, glucose intolerance or insulin resistance, and subjected to those added complications. Patients with chronic kidney disease will acquire cystic changes, some of which can degenerate to renal cell carcinoma. The only good thing about it is that they tend to be slow growing and can often be caught before they metastasize and treated effectively by nephrectomy. And then finally, aluminum toxicity, which results in what we used to call dialysis-associated dementia, which was ultimately found to be the accumulation of aluminum in the brains of patients. which is a rare complication now because of changes in medications and the dialysis procedure. I'll just mention it briefly. Aluminum or alum is used in municipal water supplies to precipitate out flocculated material and make the water look clear and nice to drink. And for the average person, there's no problem with a little bit of extra aluminum in the water. But dialysis patients, we run about 120, 150 liters of dialysate solution through the dialysis machine. So a dialysis patient, as opposed to something drinking water, is exposed to much, much higher volumes of water. And if the water has aluminum in it, those patients can actually absorb the aluminum across the dialysis membrane and develop aluminum toxicity. So in dialysis facilities, the water is processed by a reverse osmosis system to remove even trace amounts of minerals such as calcium, magnesium, and aluminum to prevent toxicity. So I've actually never seen aluminum toxicity, and we probably should never see it in the future either. So I mentioned that dialysis alone is not adequate to control the fluid and electrolyte derangements. So patients need dietary restriction that I mentioned earlier. We also restrict dietary phosphate intake. And we want to ensure that the patient has adequate but not excessive protein intake. I'll go through this quickly since I'm sure you had an extensive lecture on this. So mineral and bone disorder in chronic kidney disease, and particularly dialysis. As there's a progressive decline in nephron mass, there's an increased phosphate load per nephron that has to be excreted. And this is something new that's come up in the last several years. Researchers have discovered that there's a growth factor, FGF23, which is a phosphotonin. That is, it's a phosphaturic hormone. It's actually released by osteocytes. It seems to be released in response to an increase in phosphate load or dietary phosphate intake. This hormone actually suppresses 1-alpha hydroxylase activity in the proximal tubule, leading to reduced 125 vitamin D levels. So the hormone itself reduces phosphate reabsorption in the proximal tubule by causing an involution of the sodium phosphate cotransporter. So that results in less phosphate reabsorption and more phosphate excretion. At the same time, 125 vitamin D stimulates phosphate absorption in the proximal tubule. So inhibiting it by FGF23 will also reduce phosphate reabsorption. The reduced 125 vitamin D, parathyroid cells have a vitamin D receptor, and the loss or inadequate production of 125 leads to a loss of feedback inhibition, which then results in increased parathyroid hormone secretion. Parathyroid hormone secretion also reduces proximal tubular phosphate reabsorption. So the combination of all three things, FGF23 itself and its related effects in terms of reducing 125 vitamin D production and increasing PTH secretion, all three things help to increase or reduce phosphate reabsorption in the kidney, thereby achieving more phosphate excretion, and helps to maintain phosphate balance. And in fact, most patients with advancing chronic kidney disease will not develop hyperphosphatemia till their GFR gets below 20 or even below 15. And that's because of all these compensatory mechanisms. Unfortunately, when you do get that low in terms of kidney function, then these compensatory mechanisms no longer work and the patients get hyperphosphatemic. Unfortunately, there are detrimental effects of FGF23, which Dr. Nicholas might have mentioned. There are studies showing that FGF23 actually stimulates FGF receptors in cardiac myocytes and actually causes myocardial hypertrophy. So the left ventricular hypertrophy that we see in people with chronic kidney disease that we used to say, oh, it's all from hypertension, it looks that FGF23 contributes to that. Excuse me. And then likewise, the complications of severe secondary hyperparathyroidism occur as a result of this mechanism. So dialysis alone only removes about, and that's with dietary phosphate restriction, regular dialysis treatment will take out about a day's worth of phosphate intake. which is fine, but that patients only treat 3 times a week and doesn't take away the phosphorus that they accumulate the other 4 days. So what we try to do is, besides putting them on a restricted phosphate diet, we also use phosphate binders that patients take with their meals to reduce GI tract absorption of phosphorus. And basically what these are cationic substances that will bind phosphorus in the gut. And many people still use calcium-based phosphate binders, calcium carbonate, calcium acetate. There's no good large prospective studies, but there are post hoc analyses of some studies comparing different phosphate binders that have shown that the calcium-based binders tend to produce a more rapid progression of vascular calcification. So some nephrologists, including myself, shy away from calcium-based binders and go with the non-calcium-based binders. The most common one in use today is a large cationic polymer called sevelamer. There's also lanthanum that's available. Magnesium has been used. Aluminum had been used in the past, but because of the risk of aluminum toxicity, it's no longer used. And actually, currently on the market, there are 2 new phosphate binders that have come out that basically uses iron as the chelator for phosphorus. So there are national goals. There are there's a national guideline set by the Kidney Dialysis Outcome Quality Initiative, KDOQI, and an international consortium called KDIGO, Kidney Dialysis Improving Global Outcomes, that have set goals of therapy using the best available data we have, which in some instances is rather limited. But in terms of phosphate control, we try to have patients' serum phosphate be as close to normal as possible. And again, we use activated forms of vitamin D to suppress parathyroid hormone. And then there's a third medication that I want to mention, which is called a calcimimetic, which is cinacalcet, which is an activator of the calcium-sensing receptor. So parathyroid cells also regulate parathyroid excretion by the activation of the calcium-sensing receptor. Cinacalcet is a medication that actually shifts the binding curve, or I should say the response binding curve of the calcium-sensing receptor, so that there is increased activation of the receptor at a lower calcium concentration, basically fooling the parathyroid cell into thinking the calcium level is high and then suppressing PTH secretion. And again, there are goals set by these national and international consortiums as to what the PTH level should be. And as you might surmise looking at the numbers, we really have no idea what the optimal PTH level should be in a dialysis patient. So the guidelines are rather broad. And I'm almost done. I said at the very beginning that we use a near physiologic dialysis solution. Again, it's not exactly physiologic because we can manipulate or choose different dialysate solutions in order to favor or limit the efflux or influx of electrolytes across the membrane. So for example, the 2 most common things we manipulate is the potassium of the bath and the bicarbonate of the bath. So someone with a higher potassium concentration in the blood will use a lower potassium bath to have a steeper gradient to favor potassium flux out of the patient. Or if someone's very good with their diet and their potassium level is normal, we would use a more normal concentration or physiologic concentration of potassium in the dialysis solution. Bicarbonate, depending on how much protein a patient ingests, the amount of acid they generate will also be different. And so there are different levels or degrees of acidosis in different dialysis patients. So we can put different patients on different bicarbonate baths. Someone who ingests a lot of protein and has a very low, and it generates a lot of acid and has a low serum bicarbonate will purposely use a higher bicarbonate containing solution to flux more bicarb into the patient to help correct that abnormality. And those are the 2 most common things that we manipulate, choosing the potassium of the bath, choosing the bicarbonate of the bath. To a lesser extent, we can also manipulate, excuse me, we can manipulate the sodium of the bath and to a lesser extent also the calcium of the bath and the magnesium of the bath if we need to. Now, the only problem is dialysis removes solutes and electrolytes, but it doesn't discriminate. So patients will lose essential elements. So, for example, water-soluble vitamins readily diffuse across the dialysis membrane and are lost, and so patients are placed on supplements to correct that. And then the last thing I'll mention is that, which you should be aware of in the modern healthcare that we face, is that more and more things are regulated by the Centers for Medicare and Medicaid, and especially dialysis, which is an extremely expensive form of treatment, up to about $50,000 per year per patient. There are the guidelines that have been established are often used as the quality measures by which nephrologists and dialysis facilities are gauged. And it'll probably spread to other fields of medicine. Okay, so I will entertain any questions, or if not, give you a break before your next lecture. Oh, okay. Hi.
Nocturnal hemodialysis. Do you perform it over a longer time because you're sacrificing convection, or just?
So the idea is that you do it slower, so that you take off fluid over a longer period of time, and patients tolerate that better. So you can then often get off more fluid, achieve a lower what we call dry weight, which often helps control the blood pressure better.
Because you said that it helped with the medium-sized solids.
Yes.
Diffusion.
Right.
So I thought that was by convection.
So larger molecules are moved by diffusion, but they move very poorly through small pores. They actually move better, and again, this is what I said, for reasons I don't understand. Convection will remove middle molecules, larger molecules, better than diffusion.
Okay.
So, but when you're relying on diffusion, you're right. All you can do is run it longer.
Okay. Yeah.
And you will get some movement. It's slow and poor, but if you run it longer, you'll get more off.
That's true. So the convection isn't really that compromised anymore by this lower flow rates?
Well, so convection depends only on how much you ultrafilter. And that's independent of what the blood flow rate is. The flow rates, blood flow and dialysate flow that are used, which are like half of what we use for conventional dialysis, those flow rates will affect diffusion much more than convection. But convection depends only on the more fluid you ultrafilter, the more convection you'll get. Right.
Thank you.
Is that yours?
Yes.
Everyone will see your lecture, even though they're not in the hall.
Oh, well, no, I know. So,
It's in the world.
it's in the world.
Sooner or later, we would have to be here.
Well, we're sort of wondering how long it was before.
Yeah.
So what do I need to know? Just plug it in?
I guess after your lecture, people wonder, why does anybody go on dialysis?
Have to find those kids.
That's the problem, right?
Was it the Times had an article about the linking?
Yeah. All right. You carry it over. You just open it from your drive. Everyone has it anyway. It's not. I don't know if it runs better off the.
Oh, I just ran it off the US.
You ran
Yeah,
off the USB.
the thumb drive, it's fine.
All right. So.
And yeah, the medical students will all have this, right? We submitted them, they'll have it. They can look at it,
Yeah.
right, in addition to the videotaping. All right. Hope I didn't put too many of them to sleep for you. Good to see you.
Thanks a lot. See you later. Grab some coffee, go.
Good morning. Good morning. I guess we'll get started. This is working? Yes. Okay. It seems to need to be higher up. So I don't usually wire myself up for sound here, so if there's a problem, just holler. Wave your hands if you can't hear me. We're going to take a tour through the realm of kidney transplant. I am a nephrologist like all the other nephrologists who have paraded before you, and I'm the medical director of the kidney transplant programs, which is a kind of a sub-area in the nephrology world. Obviously, we're dealing with kidneys, so all the things you've heard apply to kidney physiology as a transplant, but of course there's a whole superimposed issue of transplant and transplant immunology and a whole lot of other stuff. So we're going to talk a little bit about the current state of kidney transplant. I'll set the context somewhat in the treatment of end-stage renal disease. We'll talk a little bit about immunosuppression. We'll go over outcomes. We'll go over how kidneys are distributed and some of the challenges in the field. By way of a complete and a very brief summary, kidney transplant is a very successful endeavor. The short-term outcomes are certainly excellent. The long-term outcomes are good, but could be better. We don't have enough organs, so that makes it a kind of a unique area in medicine, which I'll touch on. And as I said, long-term, we wish we could do a bit better. So kidney transplant is a treatment for kidney disease, for chronic kidney disease. It's considered to be an appropriate treatment when the GFR is at less than 20%, which some people say less than 20% of normal. But about GFR under 20 is a time that people can actually get listed for a deceased donor kidney transplant. Transplant we don't think of as a cure. We wish it were a cure. Sometimes it is a cure. But people who have a transplant have to take medicines to prevent rejection for the rest of their lives. For someone, a younger person getting a transplant who hopefully would live another 50 years or so, we are pretty certain that we don't know how to make kidney transplants go for 50 years. And so a young person would probably need another transplant. And of course, we don't cure the underlying diseases. It's a treatment for kidney failure. Obviously, it's a replaced kidney. One of the unique areas about it is that end-stage renal disease is paid for by the federal government, essentially, a huge amount of it, through Medicare. So Medicare entitlement, you get Medicare when you're 65, or if you're disabled, or if you have end-stage renal disease. It's the only single disease entity that Medicare pays for, and it costs them up some enormous amount of money, $20 billion or something per year. So so they're rather interested in what's going on in the area of end-stage renal disease. I don't know if Dr. Valeri touched on some of the regulatory things, how they look over the dialysis enterprise, but there's a very complicated regulatory network of people looking over the field of transplantation. Part of that is because, as I'll get into, we don't own the kidneys. We shepherd deceased donor kidneys. When someone dies and the family donates the kidney, it doesn't belong to me, it doesn't belong to the patient, it doesn't belong to the medical center. We shepherd this national resource to the patients per a national system of allocation. And that's overseen by the federal government. And they pay for it and they want to know what they're getting for their money, essentially. So we'll talk about that a little bit. But it is unique in that area. So of course, end-stage renal disease transplant's not the only option. Very important to remember that. For a patient who's 90 years old and whose kidneys fail for one reason or another, obviously no treatment might be an appropriate option. And then, of course, you've heard about dialysis and then kidney transplant, either from a deceased donor or from a living donor. Maybe Dr. Valeri showed a slide like this or a similar slide, but unfortunately, dialysis and kidney transplant are both quote-unquote growth industries. More and more people are developing end-stage renal disease. I guess in part because so many people are diabetic and hypertensive, which are the two leading contributing factors to kidney failure. So more and more people go on dialysis, more and more people get listed for transplant, and we have a steady flow of transplants, and there are more and more people living with a transplant. If you look at the prevalent treatment of people with end-stage renal disease, of all people who have kidney failure these days, about 3/4 are on dialysis, about 1/4 are running around with functioning transplants. Diseases I briefly touched on, and you've probably heard this already. The most common diseases that lead to kidney failure are diabetes and hypertension, and this is unchanged and continues to be the major source of patients with kidney disease. If you look at the age, middle-aged people account for the most common, the high numbers of patients. Older people have the fastest growth rate of all in patients reaching end-stage renal disease, partly because people are surviving other conditions longer, and diseases, again, diabetes and hypertension that will affect the kidneys. They live long enough to end up with kidney failure, and then with all the things we do in terms of bypass surgery and everything else, and keeping people going, then they're interested in kidney transplant. And so there's been a gradual shift towards an older population, which of course poses its own challenges in terms of the immunosuppression and going through surgery and that sort of thing. Luckily, if you look at the incidence rate, it's actually kind of stabilized. There was a period of time when people talked about an epidemic, and you can see the rate was rising. The rate is now stable, which means that the same number of people, more or less, are ending up in renal failure every year, which is a pretty substantial number, but at least it's not, as a rate per million population, increasing consistently. So you can see it's these little brown dots, it's kind of leveled off and around zero, so it's not changing much, which is, I guess, somewhat of a triumph. But there's a huge influx of people who are developing end-stage renal disease who need treatment every year. So in kidney transplant, patients get, in general, 99% get a single kidney. Obviously, from a live donor, it's a single kidney. From a deceased donor, on rare occasions, you can use both kidneys for a single recipient. Usually, that's the case if we're concerned about the quality of the kidney, and we think one kidney might not be good enough. We'll sometimes put in two. The artery and vein have to be hooked up to the iliac vessels so that there's blood supply in and out of the kidney, and the ureter is hooked up to the bladder so that the patient urinates the same way, and the kidney is placed in the iliac fossa. So it's rather unobtrusive. You wouldn't know if someone had a transplant or not. It's rare to remove the native kidneys unless they're causing a problem, so they just stay where they are. And so the surgical aspects of this are relatively straightforward for 99% of the patients. The major barrier is the immunologic barrier. That, of course, it's not normal to have someone else's kidney in your body, and your immune system is rather attuned to that sort of thing. And if we did nothing, everyone would just reject their kidney. Why do we do transplant? Has a considerable number of advantages compared to dialysis. Of course, you have much better renal function. So the average renal transplant patient has a GFR of somewhere between 40 and 80, probably the vast majority between 40 and 50, which again is not a normal GFR, but is clearly enough to have an excellent quality of life. And for almost all patients, it's much better than the quality of life on dialysis. People live longer, and the various fluid and electrolyte abnormalities are more or less corrected for almost all patients. So life is much better. And people live longer. The disadvantages are the immunosuppressive drugs, essentially, which have their side effects, which I'll touch on. And always living with the possibility of rejection, or kind of knowing that, well, this might not last my whole life, or something could happen tomorrow, and, or I could have some life-threatening infection from the immunosuppressive drug. So that's kind of the downside. And of course, like any medical treatment, it doesn't work for everybody, even though someone might walk in and they look like they're going to do great. They might just, despite everything we do, reject the kidney in short order and be sick for quite a while from all that. Luckily, that's a very small percentage of patients. So it is a huge advantage for most patients. So as I mentioned, transplant is unique. And these kind of points will come up a little bit throughout the talk. It's the only area in medicine in which we have to ration the care. So if anyone wants a hip surgery, anybody you need any kind of aortic valve replaced, anything else you need, they can just call the factory and crank out a few more of whatever it is you need, and then put them in. Limited only by your medical condition. Transplants, there is no kidney factory. Maybe ultimately we'll have one, but So this is a unique area. There's no other area in medicine that we really ration care just based on the fact that we don't have enough of the treatment available. So this poses a huge number of questions, which I'm not really going to say much about. The basic question, I guess, has been kind of summarized as equity versus utility, which is, do we just give kidneys to those people who are going to live longest and have the kidneys for a longer period of time, or do we give everyone a chance? So if someone is 70 years old, and we know they're not going to live another 40 years, but they've worked their whole life, they've paid taxes, they've paid into the Medicare system, should they have an equal shot at a kidney compared to a 30-year-old who we'd like them to live another 50 years? So how do we weigh these things? So this is a huge challenge, which in a way it's one of the interesting areas in the field. It doesn't really exist in any other area of medicine, not to the same degree. There are always choices about what treatment's appropriate. The other thing is it depends completely on the trust of the public. So again, we can't produce organs if families don't donate organs after the death of a family member, or if someone doesn't decide, I'm going to give a kidney to my friend or my brother or sister or my wife or husband, then the whole system comes to a halt. So whatever we do is quite transparent because Medicare, again, monitors it and makes all the data pretty public. But the people have to believe that we're actually doing this for the good of the public, that we're not, the kind of things you might have seen on Grey's Anatomy where someone donates a heart, and then the surgeon runs off with it and sells it to somebody on the side or some other kind of crazy thing like that. Those kind of things are very damaging to people. If someone watches that show and the next day their brother gets hit by a car and someone asks for the organs, they're going to say, you must be nuts. A surgeon's just going to run away with it and get rich. So it's crucial that what we're doing is transparent and it meets the public's approval. I mentioned the Medicare, I mentioned the regulatory, and everything is basically public. You can go online to the SRTR and you can look up our results. If you want to know if you're 28 years old and you got a transplant at Columbia, what happened in the past 10 years, you can pretty much get that data online. Or any other center, or your blood type B, how long are you going to wait at the University of Wisconsin versus the University of Miami. It's all there. And what are the outcomes? So in the U.S. in 2014, there are roughly 18,000 total kidney transplants. It a little bit depends how you count them, but this is kidney alone, and then for diabetics, some people get a kidney and pancreas combined. Some people with advanced liver disease also have kidney problems, and so they get a kidney liver, and similarly with the heart patients. So there are a few thousand of combined organs done. About 2/3 of the transplants in this country are from deceased donors, and about 1/3 are from live donors. In the live donor population, about half of them are from living related donors, that's genetically related, and the other half are from living unrelated donors, either most commonly from a spouse or from friends or from others, and I'll talk about this. As of a few days ago, the total waiting list was pushing 102,000 candidates. About 30% of those or so are so-called inactive, which means they're getting their evaluations and they're sort of temporarily on the waiting list until all the work is done. But there are plenty of people waiting for transplants, and in 2014, 36,000 new candidates got listed. So, if you look at 18,000 done and 36,000 new candidates, you can see obviously there's a problem, and so that the list gets bigger and bigger and bigger, and the number of kidneys, which I'll touch on, doesn't improve sufficiently to keep up with the demand, which puts a lot of pressure on everyone in the field to try and figure out what to do about that. If you look at 5-year survival, and this slide's a little bit old, but it's the data has been done like 100 times. If you compare patients having a transplant, which is in this, I guess, teal-colored bar, compared to patients on dialysis, and look at the survival probability 5 years after either you get listed for a transplant, either you have a transplant or you stay on dialysis. So the patients are more or less equal. Any way you slice the data, you get the same result, which is at 5 years, you have essentially twice the chance of being alive after a kidney transplant compared to sitting on the waiting list on dialysis. It's just an enormous advantage. On the dialysis, you can see the different diseases make some difference in survival, but nothing's like having a transplant. Hence the increasing demand. So if you look at the success rates for live donor compared to deceased donor, you can see that, number one, that the live donor transplant success rates are always a little bit better. So why is this? The main reason is that, of course, when someone presents and says, I'd like to donate a kidney to my sister or brother, they have a complete evaluation. We make sure their kidneys are normal. We can test them up and down and make sure that the kidneys are absolutely fine, that the surgery takes place simultaneously, essentially. So that in one operating room is the recipient, where they're getting everything ready, and then in the other room is the donor. The kidney is removed, that essentially immediately gets implanted. Everyone is medically stable, and there's no, the kidney really doesn't sit outside of anyone for any period of time. For deceased donor, number one, the patient's dead, and I'll go into that a little bit later. The kidney we have to figure out who's going to get that kidney. So in general, it's going to sit around for 12 to 24 hours on a little pump. Obviously, being dead or essentially brain dead is not a healthy state, not only because your brain is dead, but because that has a lot of other influences systemically in terms of inflammatory markers. And so those kidneys are, and also we don't have that much time to know exactly what is the kidney function. Some people have had hypertension, and the kidneys aren't perfect, but they're still quite good. So for all those reasons, the success rates for deceased donation are never quite as good as for live donation. And over the years, that takes a progressively bigger toll. So if you include rejection and patients dying with a transplant, so a patient comes to see me and they want to know what's my chance of success, I give them the overall numbers, which is what's the chance that a year from now you can come back in the office and your transplant will be functioning well. So it doesn't really matter to the patient so much if they're dead but the kidney was working when they got hit by the bus. That's not really very useful. So the one-year success rates for a live donor is over 95%, and for deceased donor is just around 90%. And then it drops down to about 80-some-odd% at 5 years, and around 60% for the live donors, and between 40 and 50% for the deceased donors. Again, this includes patients who die. So if you're transplanting people in their 60s who have had diabetes and hypertension for 30 years and heart disease, 10 years is a long time for that person to survive. And I'll get to the reasons why, but in some, about half of the transplants fail because people die with a functioning transplant. The other half, the patient's alive and well, and the kidney has failed for one reason or another. But these are the overall success rates. And you can see that what I kind of just said in graphic form here. This is all-cause graft failure. And so this is the probability of failure. So, of course, at 1 year it's lower, at 5 years it's higher, and at 10 years it's higher. The graphs, these are a little bit confusing. So this is all-cause graft failure. The dark is the return to dialysis, and the light-colored line is death. So you can see that, and these are the year of transplant. So if you're transplanted in 1992 or 2002, your chances of dying in 10 years hasn't really changed much. At 10 years after the transplant, we haven't made much progress in that area. On the other hand, your chances of rejecting the kidney or the kidney failing, and you're still alive, is actually improved considerably. So the overall 10-year graft loss is improved. So this is for deceased donor transplants, and it's basically the same for live donor transplants. The numbers are all a little bit better, but it's about the same. So it's about 50-50 in terms of the causes of kidney failure at 10 years, or really almost at any time, between the patients dying and the kidneys failing. So our own center is one of the top 10 biggest programs in the country. We do 240 or so transplants every year. Since half our program basically depends on deceased donors, we don't have control over that, and so that goes up and down, and the numbers go up and down. So it's about 50-50 last year, which is, as you can see, a little bit different than the national average. About half of the live donors are from genetically related donors, and the others are split between living unrelated donors and something called the paired exchange, which I'll talk about towards the end. So what's the issue? How come the kidneys don't last? Well, of course, it's about your immune system, alloimmunity. And the major barrier to success, and I'm sure you've had this elsewhere, the major histocompatibility encoded proteins. So your MHC is rather important in your self-recognition. And there are kind of two different classes of HLA antigens. Class 1, which are HLA A and B, and C, although people, after all these years, still argue about how important HLA-C is in organ transplant. And then there's a class 2, which is the HLA-DR, DP, DQ. And so class 1 are on all nucleated cells, and class 2 are on antigen-presenting cells, B cells, and sometimes endothelial cells, and sometimes tubular epithelial cells in the kidney, especially when they're activated. These are all encoded for on chromosome 6. And this is really the major, issue that we face. If we're only surgical, we'd have, 99% success rate. So in some ways in transplant, although this is not, this is the kind of overall model of what goes on, is that the class 2 molecules, which are generally recognized by CD4 T cells, are kind of the most important, and they initiate the immune response. And the class 1 molecules are more or less the targets of the response. There's lots of animal models that can show that it doesn't have to function this way. And clearly you can have an immune reaction against class 2 molecules. And I'll talk about this a little bit at the end. But it's kind of the overall, 30,000-foot view of what's going on here. The class 2 molecules initiate the rejection process. So in terms of best kidney you can get, if you think about this a little bit, obviously the best you can do is if you have an identical twin. Might not be so great for your twin, but if you have some kidney disease and your twin doesn't, and they're healthy and they want to donate, then essentially you don't need any immunosuppression because they're genetically identical, they're HLA identical, and there's basically no rejection is going to occur. So that's the best you can do. It's not that common, but certainly maybe every 4 or 5 years we have an identical twin who donates to their sibling. The next best thing is an HLA identical sibling. So we're talking only about chromosome 6. We're talking about simple Mendelian inheritance of a single chromosome. So between you and any one of your siblings, you have a 25% chance of having the same chromosome 6 from your parents, from each parent. And so 1 out of 4 siblings would be HLA identical. So that's the next best thing. And it's important to remember that despite what I said, that HLA is not necessarily the only target of rejection. So there are so-called minor antigens, which are really not that well understood, and we don't have any good way of testing for them. And so HLA identity is not at all the same as identical twins, where everything is the same. So a lot of other things, we're just only looking at chromosome 6, so lots of other things are not the same. And so these patients do need immunosuppression, but they do incredibly well long term because the HLA is the same. The next best kind of kidney is any other kind of live donor. Beyond that would then be an identical deceased donor. So our system of allocation does prioritize if there's an identical matched deceased donor, which would sound like, how can that ever happen? But it happens hundreds of times every year. Someone gets hit by a bus in Seattle and they're identical to someone in New York. So that kidney will fly across country to the person in New York because the outcomes are that much better. It sounds insane, but it happens on a regular basis. And then in the overall gross categories, then any other deceased donor is then on this rank order would be the worst outcomes. And then outcomes depend somewhat on how good is the HLA match. So this is a cartoon, rather unsophisticated, of what goes on in terms of your immune system. So antigen has to be presented to some T cell that's able to recognize it through its T cell receptor. This alloantigen is from the donor. It's some chopped up piece of donor HLA that is able to be presented by your immune system. And when the kidney first goes in, it may be HLA on the surface of the antigen-presenting cells that came from the donor, and they're donor cells, but sooner or later these are replaced by your own antigen-presenting cells. T cells recognize this through the T cell receptor. They also have co-stimulatory receptors, which have to be engaged to fully activate the system. Without going in a lot of details, calcineurin is a phosphatase that's activated that enables the T cell to be activated. The T cells produce growth factors. Here it's kind of summarized as one single interleukin, IL-2, which is kind of critical in the amplification of the immune response. Other T cells respond to this through a variety of signals. Through the mTOR pathway, T cells get fully activated. they divide, and you have antigen-specific either cytotoxic T cells or B cells, which then can develop into plasma cells producing antibodies that are specific for this antigen. So this is all kind of immunology in 60 seconds. This is kind of our understanding, and the reason I show this is because of all the drugs, and I'll show a little bit in a second what the targets are. But one of the reasons the success rates are so good these days is because we have a whole lot of drugs. So we use steroids, which are kind of impact immunity in many different directions. We have drugs that are relatively specific and inhibit lymphocyte proliferation, essentially through inhibiting purine synthesis, which is mycophenolic acid and azathioprine. Azathioprine came in over 50 years ago and really kind of created the field of transplantation and made it, gave some reasonable success rates. We have calcineurin inhibitors, which inhibit your T cell activation, mTOR inhibitors, which inhibit response to growth factors. We have antibodies, which essentially target cell surface molecules on various subsets of lymphocytes and destroy the lymphocytes or inactivate them. And then we have one agent that's a co-stimulatory receptor blocker. So obviously, we're able to target the immune system at a whole lot of different places. Steroids are pretty nonspecific, so they inhibit things in a variety of ways. Here, I kind of put it at the antigen-presenting cell. We have co-stimulatory blockers. We have calcineurin inhibitors. We have mTOR inhibitors, which prevent cells from responding to growth factors. We have lymphocyte proliferation inhibitors. So we're able to target the immune system at multiple places as appropriate. The most common regimen essentially is a calcineurin inhibitor and mycophenolate. 90% of patients, plus or minus steroids, have that regimen essentially as their long-term immunosuppressive regimen. So you kind of target antigen presentation, you target the lymphocyte proliferation, and you target the calcineurin pathway. And that's really what gives us our stupendous short-term results. In terms of matching donors and recipients, the one thing that's kind of essential, and it's a little less essential than it used to be, but it is still very important, is the presence of anti-donor antibodies. So why would someone make an antibody against another person, against another person's HLA? So the reason for that, of course, is exposure to someone's HLA. And the reasons that would occur is either from transfusion, prior transplant, or through pregnancy. Somewhere up to 30% of women who make antibodies against the HLA antigens of the father. So that's an issue. And the other type of antibodies we all make are isoagglutinins for ABO incompatibility. So as you know, if you're a type A, you have anti-B. If you're a B, you have anti-A. And if you're an O, you have anti-A and B. And so that's a barrier you can't just put in an ABO incompatible kidney, because those antibodies will wreak havoc in the short order. Similarly, high enough levels of anti-HLA antibodies are also a barrier that you can't cross without getting that antibody level low down. The HLA matching, as implied from what I said, is desirable. It's the best match is great to have, but you can do fine for years on a poor match. It's not as good. The odds of success long term are not as good with a worse matched kidney, but it's far from zero. So HLA matching is desirable. The absence of anti-donor antibodies is at any high level is essential. One word about rejection. Rejection, in a sense, is simplified down to three flavors: hyperacute, acute, and chronic. So hyperacute rejection almost never occurs. It's kind of immediate thrombosis at the time the graft is put in, and it's essentially due to the undetected presence of some antibody. And as soon as the kidney's put in, clamps are open, the kidney's reperfused, the antibody goes in and immediately starts causing problems on endothelial surface. And then within an hour, the kidney just clots, and that's the end of it. There is no treatment for that. So that's extremely rare. Our ability to detect anti-donor antibodies, the technology has gotten incredibly sensitive. And so this almost never happens. But it does occasionally and rarely occur. Acute rejection is kind of what we are always monitoring patients for. We monitor their kidney function. If the creatinine goes up, indicating a decline in function of the transplant, then we start looking around to see what might be the problem. And somewhere between 10 and 25% of patients, depending upon the report and the center, have an episode of acute rejection where there's a deterioration in the short term of function related to either development of new immunity against the allograft or some activation of memory cells that starts to create inflammation in the kidney. And this can either be cells that go in, lymphocytes, T cells essentially go in and start attacking the kidney tissue, particularly affected in the tubules or the arterioles as well. It can also be a vascular type of rejection. Rejection can also be antibody-mediated, so if you start making anti-donor antibodies or anti-HLA antibodies against the donor, then those go in and start also damaging the kidney. So there are two different types of acute rejection, either cell-mediated or antibody-mediated, and they can occur together. So this is generally reasonably successfully treated. We have a lot of very effective medicines, particularly against cell-mediated rejections. Chronic rejection is a much bigger problem. It's quite common. You could say it's almost universal. It can also be cell-mediated or antibody-mediated. And it's a very slow process over many years that ultimately causes probably half of the kidneys to fail, essentially. And it's something we really don't have a good treatment for. It's a slow process, and the treatment of acute rejection is a very short and very intense period of high immunosuppression. But for a chronic rejection, you can't safely give a prolonged period of intense immunosuppression without, first of all, we don't know if it would work, and secondly, the risk is much too high. So this is a problem that really cries out for some kind of solution and better understanding. I kind of talked about this, the HLA identical donor. These are kind of long-term outcomes from a while ago, but is better than any other live donor by 20% long-term outcomes. And this is expressed by the half-life, so half of the HLA identical kidneys, again, including death of the recipient, are going almost 25 years after they're put in, which is pretty remarkable. For any other live donor, that's all pretty much the same, whether it's a parent to a child, whether it's a brother or sister that are not HLA identical, whether it's your wife or husband who donates a kidney, whether it's some stranger who shows up at your doorstep and wants to donate a kidney to you, or whether it's a child to a parent. Those long-term results are pretty much similar. There are small differences, but you can see, interestingly, the child to parent is a little bit worse outcome, possibly because there's some sensitization in the women who have carried the child, and then the child donates the kidney. Those long-term outcomes aren't quite as good. The effect of HLA matching long-term, you can see, is not huge, but if you look at the one-year graft survival, this is like 6 out of 6 mismatch compared to 0 out of 6 mismatch. So the best match, the one-year graft survival, is about 93%. It's a little old data, but it's pretty similar, and it's only a few percentage points lower, even for a complete mismatch. But when you get out to 5 years, you can see it starts to take its toll. And it's kind of progressively gets worse and worse to the degree of mismatch. So there's kind of a stronger antigen stimulation to rejection as time goes on related to HLA mismatch. And this is the same shown graphically, that the 0 mismatch, again, these are deceased donor transplants, not live donor transplants. The 0 mismatch, deceased donor, and the 1 mismatch, there's a little difference, and as you keep getting worse and worse in this database, it gets worse and worse, and rejection gets more and more common. So it does play a role. If you look at which mismatch is more likely to result in a worse outcome, as I mentioned at the beginning, the HLA-DR mismatch has a much stronger effect than the HLA-A or B. So again, because in a broad sense, the class 2 antigens are those that initiate the immune response, more so than the class 1 antigens. Again, this is an oversimplified model, but the data do support that this matching seems to be more important. And this does have an effect when you talk about allocation of kidneys, because we do prioritize. People get extra points towards a given kidney if they're HLA-DR matched. So how do we give these kidneys out? Well, this is not the way we like to do it, where people go online and paint a sign and they're begging for a donor. Obviously, this is not the system that we like. So the first thing to remember is that when we talk about allocation in general, we're talking about deceased donors. Because if you have kidney failure and you come to a transplant program and say, hey, I need a kidney, you come to us, we're going to ask you, do you have anyone who wants to donate a kidney to you? And so you say, yes, yes, you know, my family knows I'm sick, my parents want to donate, my brother wants to donate. So that there's no allocation system required for that. That's, you know, that person is going to donate to you, and that's the end of that. So there's no, you know, you don't need a big system to figure that one out. But for the deceased donors, as I mentioned earlier, it's a national resource that we shepherd to appropriate recipients. And so it has to have a whole system to keep everyone doing the same thing. So it's locally distributed. Each area has an organ procurement organization. The one in New York is called Live On New York. It used to be called the New York Organ Donor Network, but that was kind of, people thought that when families where a loved one was just killed or just dropped dead, it was not the best message, you know, hire on from the Organ Donor Network, as opposed to something that had a more positive message, which is, although there's a tragedy in your family, something very positive can come out of this. You can save other people's lives. So the point to this is that initially organ distribution is local. So if someone gets hit by a bus on 168th Street and the family donates the organs, those organs are going to be used probably in New York City. If on that particular time, and given that particular donor, there's no appropriate recipient in New York, then it gets more regional, maybe New England, and then it gets offered nationally. So that's just the simple, broadest outline. And so the country is divided into 57 donor service areas that cover, you know, some cover several states. Some over here just cover like Long Island, and ours covers Long Island and New York City and Westchester, and a few counties are close to Westchester. Some are just single state, et cetera. Texas has, you know, all kinds of different organ procurement organizations, and they cover a certain geographic area in terms of organ recovery, and then work with the transplant programs in that area. So the kidney allocation system just changed last December. So up to that point, essentially, and a lot of things haven't changed, but the waiting time was the main determinant of who gets which kidney. So the longer you've waited, your first, you know, within your blood group, if you're compatible, that kidney is going to be offered to you. So you get 1 point per year. For HLA matching, you got a couple of points. If it was a DR, if there was no DR mismatch, you got extra points because that would have a better outcome. And people who had a lot of anti-donor antibodies, without going through the detail, it makes it very difficult to find a compatible donor. If there's a compatible donor, then we want to prioritize because those people otherwise will wait forever. And so they got extra points. And without going through the details, children get extra points. You know, because it's felt that you know, they should have the opportunity to, you know, be healthy. So they get extra points again, and then perfect match candidates. If there's a perfect match found for you, you're going to get a lot of points that might bring you to the top of the list. If you've previously donated a kidney and you somehow end up with kidney disease, you get a lot of priority. So it's a lot of different categories of people. Everything has to be thought out because you can't have some situation arise, there's no rules, and then nobody knows what to do, and you know, everyone starts screaming and yelling about who's supposed to get the kidney. So there's like 50 different subcategories that are all prioritized in some order. So this was more or less the kidney allocation algorithm, which is you get on one of 4 lines based on your blood type, and then you just wait. And it's not all that different, but some subtle changes have been made. So the limitation was, you know, number one, we were prioritizing patients with the longest wait. And it turns out that those people don't necessarily have the best outcome, but on the other hand, they've been sitting on dialysis waiting for a kidney for years, and it's sort of, well, they should have a chance at getting a kidney. So again, it's this utility versus equity. One of the other issues was that the guy who gets to the front of the line for a given kidney could be 70 years old, and he's going to get a kidney from a 20-year-old. And, you know, common sense and would tell you that the 70-year-old isn't going to live that long, and the 20-year-old kidney has a lot of life left in it. And so that seems to be kind of a waste of potential kidney transplant years. And likewise, you wouldn't want to put a 60-year-old donor kidney into a 10-year-old, where you know the kidney has some amount of senescence built into it, and whereas the 10-year-old hopefully is going to live a long time. So the system didn't address that at all. And so it seemed like we were wasting lots of potential life years of the recipient and life years of the transplant. The other problem in the system is there's a huge variability in transplant depending on your blood group and your geographic location. So you all hear about, Steve Jobs gets a liver transplant because he looks at every center in the country and he finds out where the waiting time is less, and he goes to that place because he can fly anywhere in the country when he wants to. He gets on the list and gets a liver in short order. Well, that's completely legitimate. What's not great about it is that why would someone be able to get a liver faster in Memphis compared to in New York, for equal degrees of medical illness? It doesn't make any sense. And so the system, is not set ideally to do that. And the other thing is that there's a lot of individual judgment that is exercised, and I think we think that in terms of the kidney world that there are many kidneys that aren't perfect but could be used for older patients quite successfully and get kind of tossed in the trash because no one wants to use them. And we could make better use of the resources that we have. So the main changes that went into the system is that your waiting time starts, instead of when you show up at Columbia and get listed, but you've been on dialysis for 10 years, now if you show up at Columbia and you get listed, your waiting time starts the day you started dialysis. So you could be on dialysis for 10 years and you show up here and you get 10 years of waiting time once you've gone through the evaluation and you're approved. Part of the reason for that was a lot of people are not really getting well educated on dialysis, and all of a sudden suddenly they realize, wait a minute, I could have had a transplant, And so we're trying to give those people a fair shot. We prioritize sensitized patients, and now we have a continuous rating scale of donor kidney quality, which rates all the kidneys in some kind of rank order. We also now have a calculator, and you can look at this online, estimated post-transplant survival calculator for all the transplant candidates. So what happens is we know, if one of you shows up and needs a kidney transplant while you're young and, unless you have some horrible medical problems, you're going to have a long expected post-transplant survival. And so what we do now is we do longevity matching. For the top 20% of the patients are going to get the 20% best kidneys by priority. So you have, as a younger person, healthier, although the age plays a big role, but not the entire role. You're going to have your best shot at getting the best kidney, so we'll pair those things up. Believe me, it's created a lot of disturbance in people, older people, feeling that they were getting cheated. So it's extremely difficult it took 10 years to make these changes. Since there aren't enough kidneys to go around, and if you reallocate them, then some class of people who was getting prioritized will get less priority, and they will scream like hell. And the people who are now getting more priority are going to be very happy. And it's just can't make everybody happy. So we try and do the best we can. So deceased donors. Who can be a deceased donor? So brain dead. That's the major area, either from, could be trauma, could be a stroke, could be anoxia. The family has to consent. We have first-person consent, as it's called, where you can go on the New York State Registry. You can put on your driver's license you want to be an organ donor. It's the still, even though that is legally binding, the system most of the time still functions by your next of kin saying yes or no. Centers are and organ procurement organizations are very hesitant to just override the wishes of the immediate family. All you need is bad publicity. Somebody goes to the press publishes it and say, vampires or zombies in the hospital stealing organs, and the family didn't want it, and everybody freaks out and no one wants to donate a kidney. And these things happen in real life, where, even though legally, if you die and you have a will and you say, I'm leaving my TV to my friend, that's it. Your friend gets the TV. If he doesn't want it, you can turn it down, but your family can say, wait a minute, I want the TV. It doesn't matter. That's your will. Well, this is really legally the same, but it's just not enforced. And it's kind of an oddity, but you can kind of understand why. So these people, so most of the donors are brain dead, but heart beating, and kept alive on a vent, and whatever else it takes. There's also donation after cardiac death. So a patient who has a devastating neurologic injury, most commonly, they're never going to wake up. It's this Karen Schiavo kind of situation. They're in a sort of vegetative state. They're not brain dead, but the family says, listen, Uncle Joe, he don't want to be in that state. He said 100 times, if I'm in a coma and I'm on a vent, just pull the plug. And so, I don't know how much clinical experience you've had, but we do that. I mean, that's fair. If the judgment of everyone is this is kind of a hopeless case, then we can just terminate the care. If after the decision is made, independent of the decision to terminate care, a question can come up, would you think Uncle Joe would want to have donated his organs? And the family might say, yeah, that's great. He would always said he wanted to do that. And so then the extubation can take place in the operating room. So when that happens, 90% of the people will die. They stop breathing. And then the organs can be donated once the heart stops and they're dead. Some people actually keep on going, and they breathe. And so then obviously they don't get their organs donated. They go back to the ICU or someplace else. So there's donation after cardiac death. To select a donor, obviously they have to have a good kidney function. We biopsy almost all kidneys to make, after they're removed to make sure they're okay. And they can't have any, they're tested extensively for HIV, for hepatitis, for other diseases, et cetera. HIV organ use positive donors have been forbidden, although now there's a research protocol that may allow HIV positive organs into HIV positive recipients. For live donors, I kind of went over this. You can be genetically related. You can be unrelated but emotionally related, which is a close friend or spouse. You can be living unrelated and emotionally unrelated, which is kind of internet related, where someone shows that sign on the internet and you wake up and say, I could do this. I'm going to give that person a kidney. And this happens, in the people in the same community. So the student at Columbia needed a kidney. Some other student might jump up and say, I'm going to do this for my fellow student. Certainly within a church or a synagogue, this happens, and sometimes just based on geography. Someone will say, well, the person lives in my city, I can donate a kidney. And so we are willing to do those, assuming that the people have some good reason to do this and they're not completely insane. We also have people who turn up who realize, what a benefit it is to have a transplant. They've heard stories in the press and they come forward and say, I'll just donate a kidney to anybody who needs it. You tell me who should have it. Most commonly, these are people who have seen the benefit in their family or a friend who've got a transplant, and they say, wow, I could do this for somebody. I don't know anybody who needs one, but I'm just going to do it. So we have all kinds of different live donors. The evaluation, I'm not going to go through this, but obviously they have to have normal kidneys. The surgical risk has to be acceptable. They can't have transmissible diseases. They can't be nuts. And they have to understand, they can't think that their lives will be completely transformed. I mean, or if they're horribly depressed and they're going to feel better because they do this, that's not a good idea. They have to understand, the risks and benefits of this whole thing. And it has to be completely voluntary. It's illegal to buy kidneys. We know there are black markets all around the world. People are desperate. They're waiting on a list. They have money. They're going to try and buy a kidney. It's illegal. It's a federal crime. But obviously that doesn't stop people from doing things that they think will help themselves. The urban myths, it's very important these things do not occur. So the myth that somebody woke up in Central Park and they had a scar on their side and they were missing a kidney, I mean, that's never happened. Does it mean if you're trekking in some other country to be unnamed and you couldn't get kidnapped and some other horrible thing happened? But I guess it could, but this is not, in the U.S., this has never been known to happen. When people are concerned, if I put my name on a list of a registry, you come to the ER, they're just going to let me die, take my organs. We don't do that. We don't sell kidneys on the side for profit. Rich people don't go to the front of the line. And then people wake up from brain death. So brain death, by definition, you're not going to wake up. The brain is dead. It's not, it does not come back to life. So when the appropriate testing is done, the person is brain dead. I mean, they are dead. So very important to realize that these things do, people get scared, they get mistrustful. So the challenges in the last 10 minutes or so. So we don't have enough kidneys, I mentioned that. Long-term allograft failure, I mentioned that about half of the patients, the kidneys fail because the patient dies. Why do they die? They die for two reasons in general, because a lot of patients have hypertension and diabetes for many years. There's a huge burden of cardiovascular disease at the time they come to transplant. And that doesn't disappear. And so they're still diabetic, they're still hypertensive, and although they live longer than they would have on dialysis, they still eventually succumb to cardiovascular disease, and many succumb to long-term complications of of immunosuppression which boils down to infection and malignancy. The other half or so, or a little bit more than half, eventually lose their grafts, mostly from what we call chronic rejection. Demand is increasing, supply is stagnant, so for deceased donor transplants stay about the same, and live donor transplants are they're both kind of flat. So people are trying to figure out what to do about that. And there aren't any great solutions in terms of getting more donors. You know, we change the allocation system. Maybe we can reduce the discard rate. We have ways of getting incompatible, previously considered incompatible live donors, which is ABO incompatibility. We are now able to get beyond that for many patients. We do these exchanges, which I'll talk about. And it's relatively recent that people accept this non-directed donation, where someone shows up. You know, 10 years ago, if you showed up and said, I want to give my kidney to anybody, they'd probably just send you to the psych ER immediately. But so that doesn't happen. Trying to getting more deceased donors, I mean, public education goes on and on. It has very little effect, but we keep trying. You know, state registries are good in that, you know, people can express their opinion as to whether they want to donate or not, and we can know this, and that does definitely help consent rates. So if, you know, something happens, some tragedy occurs, and the family members know that, you know, Uncle Joe wanted to donate his kidneys, then they're much more likely to say yes. So that helps. Some people think we should pay for organs. That's, as I said, it's illegal. It's not clear that it would work, but that is in the public discussion at the present time. So in terms of, you know, trying to get more live donor transplants, the sensitized patient, which is the patient with anti-donor antibodies, you know, about 30% of the list have, that number should have been updated, have anti-donor antibodies. Very hard to get them transplanted, but we are now able to remove these antibodies and at least successfully transplant them in the short term. It's a fairly complicated process, and you can see that the success rates are not as good. So this is the long-term success rates for transplants that are compatible without any anti-donor antibodies, and this is the success rates for those that are incompatible. And in 5 years, you're 10, 12% worse, and it kind of tails off pretty dramatically after that. But I mean, it's not that bad in the first 5 years, so this goes on. We did a lot of this not that many years ago, and we got a lot of people transplanted. And you know, so you know, you have 70% of the patients are doing well. You know, when you get to 8, 9 years, 40% of the patients are doing well. So that's not that bad, but it's still not wonderful. We do a lot more of what are called paired exchanges. This is relatively recent, so that if you would like to give a kidney to your brother or sister, and he or she is blood group B and you're blood group A, that's a kind of a problem. And if we have another pair in which the donor is blood group B and the recipient is blood group A, then this donor can give to this recipient, and this donor gives to this recipient. It's a simple living unrelated transplant. They're compatible. There's no antibodies, and theoretically everyone lives happily ever after. So we do a fair amount of these, and it's really simplified life a lot in terms of paired kidney exchanges or swaps. And this is done. There are several organizations that have really large numbers of patients who are incompatible and are searching with various algorithms to find compatible pairs to do this. And there was I guess, that piece in the Times, and there was a thing in the Sunday magazine section a couple of weeks ago about how all this happens. It's quite extensive. We've done lots of them here. You can do all kinds of different things. We're blood type incompatibility, donor-specific antibodies. And if you have a donor that starts out and just says, I'll give a kidney to anybody, we often say to them, well, if you can wait, we're going to find a chain of recipients. So you can give your kidney, and as a result of that, 10 people will get transplanted. Because here the blood group B gave to the B. This husband wanted to donate, but there are antibodies. He was blood group O. Whoops, sorry, I'm pointing at the screen. Could give to this person here whose father was an A, and he could give to this A, and this B could give to someone on the waiting list. And so one person enabled a bunch of transplants. So we always look for those opportunities as well. This I've kind of talked about. Again, the long-term outcomes, you know, summarized as half of the grafts fail because the patient dies, and the other half fail because of the chronic rejection. The long-term effects of immunosuppression, not surprisingly, are infection, malignancy. Some of them drugs may contribute to cardiovascular disease. Unfortunately, the calcineurin inhibitors, which are probably our best anti-rejection drugs, are nephrotoxic. And some percentage of kidneys actually get damaged long-term from the drugs that protect them from rejection. And of course, our drugs don't work as well as we'd like. There's also non-immunologic regions. The kidney may suffer a little hit at the time it goes from the deceased donor to the recipient, sitting in a box on a little pump for 12 or 24 hours. The drugs are nephrotoxic. The patients are hypertensive and diabetic, hyperlipidemic, and they may have recurrent glomerulonephritis. So there's a lot of reasons. The kidney kind of gets into it. I always tell people it's in a bit of a hostile environment when we transplant it. One of the main issues that has come to the fore in recent years is the donor-specific antibody. And so if you look at the long-term effects of people tested at one particular point in time, those who have no anti-HLA antibodies, and you look 5 years later, have the best survival. Some people make antibodies, but they're not donor-specific, but there's still something's brewing in their immune system. It's not quite as good. Those who make donor-specific antibodies have the worst long-term survival. And this is really one of our biggest challenges these days is anti-donor antibodies. All the drugs that have been developed that I showed were really developed to suppress T-cell immunity. And they're extremely effective at suppressing T-cell immunity. But we don't have any really effective anti-B cell or really anti-plasma cell drugs that are useful in transplant to prevent or inhibit ongoing donor-specific antibody production. This is really kind of a major challenge in the field at this point in terms of the long term. We think that this is the cause of the long-term graft failure in the vast majority of patients who end up having so-called chronic rejection. How are things going to get better? Well, if we knew more about rejection, we knew more about antibodies, we knew how to protect the kidney, or we knew at the molecular level exactly what drug targets we needed to develop new drugs for. We might be able to prevent injury even if some of the immune mechanisms were left untouched. We need to reduce alloantibody production. We need more kidneys. We could have better matches if we had more kidneys. The area of xenotransplant, which is taking the most likely animal where it seems appropriate, are these miniature pigs. There's a lot of immune barriers, and this has been worked on and worked on and worked on and worked on, and it doesn't seem like it's imminent. And there's also issues with retroviruses from animals that have really slowed the field up. Tolerance induction is another area which we are actively involved in, which involves a period of generally very intense immunosuppression, creating what's called chimerism, in which we kind of, for a limited or a longer period of time, have, through a bone marrow infusion, it's not really a full transplant, have the two immune systems